go on to our next speaker, Dr. MANECK NICHOLSON, and who's a consultant cataract and refractive surgery from Nicholson Eye Clinic and Hospital. And she's going to show us another very challenging set of videos. Yes, on to you.
Hi, thank you, Dr. Chitra, and thank you for inviting me to this symposium to be among such prestigious speakers. So we have a lot of exciting talks, so I'll just jump right into it. I've been working at the LV Prasad for the past couple of months, so I've utilized their videos, not the Nicholson Eye Clinic videos. We noticed a few interesting instances with the use of ZEPTO during cataract surgery, and we thought that it would make for interesting learning and discussion. So we have a couple of videos lined up. For those who are not familiar with the device, it's a disposable handheld device attached to a console which is outside in the OT. And the handheld device contains a clear suction cup which contains a nitinol ring, which is the central ring, and it lies on the anterior capsule. The first video is just a regular ZEPTO capsulotomy video. The cup it's transparent, so it allows for good visualization and you can center it on the visual axis of the patient. And once the device is centered, suction is activated, energy is delivered, and a 5.2 millimeter capsulotomy is created. So what we noticed in our initial days of ZEPTO capsulotomy was that after completion of the capsulotomy, the suction cup stayed attached to the anterior capsule. So now we always have a second instrument on table, a sort of a blunt instrument to detach this silicone skirt from the anterior capsule. And we've also now started back flushing a little DSS or fluid back into the anterior chamber. This helps detach the skirt from the lens capsule and helps us remove it more easily from the eye. This is also another example of the same incident which happened. The silicone skirt, as you can see, has sort of gone under the cut anterior capsular edge. And the second instrument is used to separate this silicone skirt from under the capsulotomy, and it's then retrieved from the eye. So going on to a couple of more different cases. This was a case of small pupil. Now the advantage is that the ZEPTO device can be used in small pupils because it's a very flexible device and can be placed under the edge of the pupil, and you can potentially achieve a good capsular access even in such small pupils. And it's quite flexible, so it can be placed under the pupillary margin. Suction is activated, energy is delivered, and again, a second device is used to sort of deliver it from under the pupillary margin. So on the flip side, in such small pupils, if you have a small pupil and if the surgery is being done under topical anesthesia, at times iris tissue can get inadvertently be caught under the suction cup and the anterior capsule. And thankfully, it was not under the ring, and we achieved a complete capsulotomy. But as you can see, the iris tissue did get caught in the suction cup, and the surgeon is having some difficulty maneuvering this ZEPTO device out of the eye. Even though this was performed from a 2.8 millimeter incision, you can see that there has been some amount of iris prolapse, and keeping a second instrument on table, as I said, is always handy and helps us sort of retrieve that prolapsed iris tissue. So the next was a case of an extremely intumescent hypermature cataract, and the surgeon here is using the second instrument to sort of press down the suction cup on the anterior capsule prior to the activation of suction. There's a lot of fluid that has come out, and it's quite evident that if we were using a forceps or a cystotome, it would have been difficult and risky in such a case. And what we noticed after the removal of the device was that there was a small remnant tag of uncut capsular tissue. And this was probably due to the presence, as you can see, of a fibrous plaque, which was then cut with microrhexis forceps, and surgery was completed uneventfully. So the surgeon uses forceps to sort of retrieve that capsulotomy, and that was the end of that case. So another interesting situation which one comes across is an intumescent cataract in which in this case especially, it was quite intumescent. Surgeon is taking his time to sort of center the device on the anterior capsular margin. But if you keep looking at that margin, suction has been activated. You can see that we've had an Argentinian flag, but energy was delivered almost immediately. And so the capsular tear was retained within the capsulotomy. It was not allowed to extend beyond the ring. At this point, we thought that maybe it had extended, but as you can see in this retro image, it didn't. And that tear was contained within the capsulotomy. Most of us operate these intumescent cataracts under peribulbar anesthesia, but this was a case being done under topical anesthesia. As you can see, the patient was a little anxious and was moving on table, which made centration of the device difficult. But if one centers the device on the first Purkinje image, it creates quite a good centered capsulotomy. And it's actually quite easy to do under topical anesthesia as well. So there were a few hiccups we faced along our journey of learning ZEPTO capsulotomy. That would not be my take-home message. It's quite a safe and easy, fast and repeatable procedure to do, especially in the hands of beginners. So thank you.
Thank you very much, Dr. Manek. I wouldn't know how many in the expert panel use ZEPTO. So I'm going to ask these questions generally. What would be the contraindications to using doing a ZEPTO in cataract surgery? Dr. Manek?
Offhand, actually, we've been using it for most intumescent cataracts. And I personally have not used it in traumatic cataracts, but I've heard of surgeons using it in traumatic cataracts, patients with corneal scars also. Possibly an extremely subluxated cataract or one where visualization might be difficult, might be cases where you might not consider ZEPTO capsulotomy. But otherwise, it's quite a safe procedure with a short learning curve. So
another question which I have, which could be taken by anybody on this platform. Is there a possibility, she did show a case where the iris got stuck, but in a small pupil and the iris is got stuck. Would just having one second instrument be enough to able to release it, or would the vacuum actually get deactivated? Does it make sense at all to use a ZEPTO for a small pupil? Anybody?
Ma'am, can I answer?
Yes, Naga.
Yes, ma'am. I have been using ZEPTO for quite some time. And as your question is concerned, in a small pupil, I've also used it with iris retractors. So it's not that you cannot use it, but when you're using a second instrument, Manek, it was a lovely surgery, but I thought using a second instrument when you're actually doing the ZEPTO is also important. And that second instrument should ideally be a cannula with a viscoelastic, so you can continue to fill in the chamber. So we don't want the chamber to shallow. A very shallow chamber and a subluxated lens, ma'am, I thought would be a contraindication to use ZEPTO. And what the point that you showed regarding the ZEPTO getting stuck on the anterior capsule, actually, if you just push in BSS from the other end, you don't even need the other instrument to lift up, because only using the other instrument to lift up many times is not enough. The moment you push in a little BSS, it frees it up, and you can easily remove the ZEPTO from the eye.
Okay. Any other question, Anaga, which you would like to take? Because I haven't used ZEPTO.
So I had a chance to use ZEPTO as a demo, and the first case which I did was an intumescent cataract. So it was a perfect thing for ZEPTO. And for some reason, what Manek showed, just like her mother, she's a good teacher. And I had an Argentinian flag sign in spite of having that ZEPTO there. And in these cases, probably I find the femto working much better compared to the ZEPTO.
Yes.
Maybe the chamber needs to be little nice and deep.
So we use viscoat. We use viscoat and Provis usually, like a soft shell technique for these cases. But in spite of that, in these cases, probably it's a bit more unpredictable. So we are talking of consistency of a procedure. So in intumescent, probably the femto works much better compared to the ZEPTO in the number of cases that you would get a nice circular capsular axis without it extending out.
Yes, femto, there is no question.
I think related to Abhijit's comment, you both Manek says that these are videos from LBPI, and I know Anaga also has a femto LASIK platform. So when you have this, and the cost of a PI as far as the femto or the ZEPTO is nearly the same. So why would you use a ZEPTO if you already have a femto with you?
Sir, it's not the same. ZEPTO is half the cost.
ZEPTO is at 10,000.
It's very, very less compared to femto. 1/3 the cost.
Oh, 10,000, am I right? I mean,
yeah. 10,000. ZEPTO is 10,000, and the PI here is around, for the cataract, if you're using a Lens 6, it's around 18,000 to 20,000.
Oh, that's the problem. You're using a Lens 6. We use both, but there are platforms where the cost of the PI is just about 8,000 to 10,000. So, you know.
Yes, but then with the LensX, you do get good incision, corneal incisions as well.
Thank you very much.